Yeah.
Awesome.
Thank
Thanks.
you.
So my name is Bailey. I'm a part of the Enloe Medical Center's community outreach team. So my team and I are working to bridge any gaps between ourselves and local providers to make sure our surrounding area is aware of the different opportunities and resources available here at Enloe and in the community. We've had the awesome opportunity so far to connect with most of our primary care providers as well as some specialty providers. And we've gone out to upwards of 8 counties and hopefully more in the future. So if you ever have a question regarding Enloe, you can always reach out to my coworker, Jack, or myself, and we're more than happy to be a good starting place for you. One of the things that we've gotten to do with all of the great feedback we've had from our local providers is work on streamlining our referral process to make sure that providers have easier access to the referral status changes, because honestly, at the end of the day, we're all trying to just keep our community happy and healthy. And the best way we can do that is making it as easy as possible. So never hesitate to reach out to us. That's what we're here for. You can reach us at community.outreach@enloe.org. We look forward to continuing our partnership with everyone, and we're really excited to share some great innovations that we have going on with cancer treatments. Thank you.
Thank you, Bailey. So Dr. Clark and Lonnie, if you're ready to get going, we're looking forward to hearing from you.
Great. Thank you. Good afternoon, everybody. And thank you to Christy and the Medical Society for inviting us to share about our new linear accelerator. My name is Jonathan Clark. I'm one of the radiation oncologists here at the Enloe Medical Center. We have 3 total. Lonnie, who is our chief medical physicist, helped compile some of these slides. But just for ease of presentation, I'm just going to present today. I love questions. So the easiest way maybe is just to jump right in and ask questions. I don't actually see when I'm sharing. I don't think I have a good way to see the chat. So I don't mind if someone just jumps right in and asks me anything. So please don't hesitate to do that. You can also do the chat, and maybe if someone can just maybe at the end or whenever is convenient, ask me some of those questions. So, so this is an introduction to our new linear accelerator. Let's see if I can move forward here. There we go. Before I launch into that, I wanted to just talk briefly about who we are and what we do. So we are a specialist who uses ionizing radiation in the treatment of cancer. There are 3 kind of big oncology fields: surgical oncology, medical oncology, and then us as radiation oncologists. Although many other specialists deal with cancer, as Dr. Kinder well knows. So ENT, urology, dermatology, many other fields deal with oncology. And so radiation can be given in a curative setting, and it can be given alone or in combination with surgery and or chemotherapy. So oftentimes surgery is done first, followed by radiation chemotherapy. It can be kind of all these different permutations. The other thing about radiation is that it can be used in a palliative setting as well. So the basic mechanism of radiation is that it causes significant damage to the DNA of the cells. Not to go too much into the weeds of things, but it can either do that directly by the actual X-ray, or it can do it indirectly, usually with free radical formation. But the whole idea of radiation is that we want to so damage the DNA of the cancer cells that they cannot continue to grow. What's interesting and amazing actually is that our normal cells can generally repair DNA damage, but cancer cells generally lack the ability to repair DNA damage, and we can exploit that difference in the repair mechanisms by treating people and allowing the normal tissues to heal while damaging the cancer cells so that they cannot heal and recover. Radiation is typically given daily, 5 days a week, usually for some number of weeks. Although we can treat people in one treatment, we do that fairly frequently. And we can treat people as long as 9 weeks. And we do that oftentimes for some gentlemen with prostate cancer. Each session, when they're here in the clinic for the treatment itself, is actually very quick. They're only here for about 15 minutes. So they're usually in and out, which makes it, even though it's a long process, many weeks, generally the day-to-day kind of operations of things tend to be fairly quick. Just to kind of walk you through just very briefly through our process, before we actually treat someone with radiation, we have to, and we call this simulation, that's kind of our technical term, but I tell my patients it's a mapping scan. So what we do is we run them through generally a CT scanner, although we'll talk about the MRI, but it allows us to have a three-dimensional map of that person's anatomy. And then as radiation oncologists, we actually map out everything that we want to treat. We kind of map out the regions that we don't want to treat. And that is done here at the Cancer Center, so they don't have to go anywhere. It's not at diagnostic radiology, and generally takes 30 minutes to an hour. And then the planning, what we do is we send out this map and kind of our instructions, and our medical physicists, who are specially trained to help derive a plan based on what we want them to do. And oftentimes, if it's a quick palliative case to someone, that can be very fast. It could take them an hour or less to do. If it's a very, very complicated head and neck plan, for example, that could take a week with all the different permutations. And our medical physicists will often labor and give us 10 different plans to look at. And so that's a lot of the processes going through making sure that we are treating someone well while minimizing damage. And so brings us right into this. So side effects tend to be local. So it's, this is more like surgery in the sense that it's a local therapy. So it's chemotherapy is a systemic. So the difference between us and chemotherapy is generally a systemic medicine, and it can affect people systemically, whereas radiation is local therapy, so it tends to affect that person in that local area where we are actually treating them. Radiation side effects are cumulative, so most side effects don't start for maybe the first couple weeks, and then they build upon each other. And at the same time, they actually take time to get better too. So they kind of peak up and then take time to get better. Concurrent chemotherapy tends to make the side effects worse, and newer systemic agents can bring uncertainty as to how exactly do we give radiation with this agent or do we not. The medical oncologists appear to be having new medicines and new drugs every single day, and it's extremely complicated to know whether or not we can treat someone. Do we need to have a break between it? But that's just as things advance, especially on the medical oncology side. So our field has benefited tremendously from the information age. So treatment has traditionally been given over 5 to 9 weeks, like I mentioned a minute ago. And some of that was limitations in planning as well as in delivery. Treatment now is becoming much shorter and very often much more focused. And that is because we have dramatic improvements in our imaging capabilities, as well as how we actually deliver the beam. So this is kind of a very old way in which people would, radiation oncologists would deliver tumors to, it says a hilar tumor, so that's the hilar region of the chest. And oftentimes radiation oncologists would just map out, basically drawing on an X-ray. And so you can see that they would have this idea of where the tumor is and have general borders based on their knowledge of the anatomy. And so this was kind of a very traditional older way in which we treated and mapped out people for treatment. Once the advent of CT scans came along, we were able to get a much better way of knowing where to target. Can you see my mouse, just out of curiosity? Okay. So this is planning based on a CT scan. So you can see, we can actually see the person's three-dimensional anatomy. And we can see the aorta. These are the black areas are the lung. And this is a lymph node right here in the mediastinum. And so you can actually see that that is now being targeted. This kind of red is a basic target with the beams coming this way. So that was a big advance in how we actually could map out and then target treatment. This is our kind of our workhorse. This is called a TrueBeam. It's made by a company called Varian. This is probably the most common linear accelerator in the US. And I should say a linear accelerator, I use that term and I know that, but essentially the beam is created in this, the X-ray is actually created in this machine. And that is what radiation is, for the most part, is very high energy X-rays. So you'll find this machine at most centers, academic centers, community centers. This is, again, kind of our workhorse, and has been the traditional workhorse for radiation oncology departments for maybe over at least 10 years now. But this is what the talk is about. This is called a Meridian Linac. And so this is what our new machine, this is not our room, but this is what the machine looks like. So Enloe purchased the MRI Linac, again called a Meridian. And there's less than 50 in the US right now. There is 3 here in California. One is in Newport Beach at Hoag. One is at UCLA, and then we have the 3rd. So it's pretty exciting that Enloe went for that and have that for people here in the North State. So traditional machines like have used X-rays actually for target localization. The newer machines, such as the TrueBeam that I showed a couple minutes ago, actually use CT scans to image. The main limitations, although those actually work well, but the main limitations of those are motion of both the target and the normal organs. So when you're doing a CT scan, you just get an image like that, and that's all you have. You don't actually know what's going on after you take that image. And in some cases, I'm going to show a picture right after this, but in some cases it's difficult to visualize the actual anatomy and actually visualize the target. This is an example. This is called a pre-treatment cone beam CT scan. This is of the abdomen. This is around the pancreatic region. And this is often what our scans look like on that TrueBeam. The quality of the scan is not as good as a diagnostic CT scan. And so you can see it's difficult to actually see what's going on. Livers over here, spleens over here. We have some bowel. There's a clip of something right in this area. Here's the spine. So this makes it difficult, often very difficult, to localize and treat areas, especially kind of in the abdomen and the pelvis. So the Meridian, what is the main difference between these two machines? A Meridian actually uses an MRI for localization instead of a CT scan. MRIs tend to have superior soft tissue delineation, and so you can see the target, and so treatment can become more accurate and more precise. This is an example of this. So over here on the far left is a cone beam CT scan. So kind of similar to the one I just showed. So this is a CT scan, liver, and this is a liver mass that is going to be seen, and then you have stomach over here. This is a MRI, and so you can start seeing that there's a mass in here. And then this is with contrast. So this is the mass here. So you can see that often there's a dramatic difference in actually what you're able to see based on the MRI or the CT scan. So where does the Meridian really shine? The Meridian really shines when there are small targets and movable targets, and we'll talk a little bit about that, as well as previously treated areas. And the main way that the Meridian can do that is this this phrase, this on-table adaptive replanning. That's a long phrase. What that essentially means is that based on today's anatomy, which may be different, and again, I'm going to show a picture of this on the next slide, but based on today's unique anatomy, you can actually create another plan. So you can spare the normal organs, or you can actually give more dose to the tumor if the anatomy allows. So this is something that is actually quite extraordinary in that you can develop new plans every single treatment, and that you can, and it allows that because either tumor changes or the change in the internal anatomy.
So Jonathan, when
Yes.
you're using this, are you doing an MRI every day then?
We are actually, and I'm gonna show you guys, but actually the MRI is going throughout treatment. So we do an MRI prior to treatment to kind of localize, and I'll kind of show what that looks like. But then also there's an MRI that's running continuously during treatment as well. So you can actually see what's going on in real time. And I'll show a picture of that. So yes, MRI every single day for the people getting treatment.
And do you have to use gadolinium at all or no?
So yep, we can use that or Eovis for liver tumors, but yes, so you can use gadolinium for treatment, but often, at least so far, we haven't done that.
Okay, thanks.
Yeah. This is an example of what this might look like. So let's say when they first come in, they get planned in this orientation. So luckily this is all nice and marked up for us. So the tumor is nice T down here. We have the liver and there's the stomach. And then let's say on the first day of treatment, which can happen is that, or the person ate food and the stomach is now all the way down in this area. See how it's abutting the tumor. And so that can definitely happen. And then let's say the second day that the stomach is now moved away a little bit. So what this allows us to do is to actually replan this, because this is different than this. So what we thought we were going to treat here is now no longer the case here. And so the Meridian allows us to replan this so that we don't over-treat the stomach, which can lead to complications. So it allows us to replan it so that we treat this, but minimize dose to this. And then what happens over on this next day, let's say now the stomach is moved over here. Now you can maybe do a plan more similar to this, but since the stomach is closer, you still have to make sure that you're not over treating this particular area. So this is what it kind of would look like day by day by day based on changes in internal anatomy. So I want to highlight two areas where the Meridian really shines. We could treat all sorts of different areas, but the two areas where the Meridian really shines is in the pancreas, as well as what I call oligometastasis. So pancreatic cancer, approximately 30 to 40% of all pancreatic cancer will be unresectable. We know that the best treatment, if possible, is resection, but there's a large number of people who cannot undergo resection for their pancreatic tumors. And traditionally, pancreatic cancer has been very difficult for us to treat. There are multiple organs here that are right around it, the duodenum, the stomach, and the liver. And those pose actually quite serious problems with us trying to get enough dose into the pancreas. And we seem to be understanding that pancreatic cancer itself probably requires more dose than what these organs can tolerate. So if you can picture that you're trying to get a lot of dose into this one target, but you have all these organs around it, that can't tolerate that amount of dose that's needed to kill the tumor. So that has been an issue that has been going on with our field, specifically in pancreatic cancer. And that comes into what we call SMART therapy, which is stereotactic MR guided adaptive radiotherapy. The beauty of this is it allows for dose escalation. So now we can really pump in a lot of dose, which we feel is actually needed to adequately kill and control these pancreatic tumors. And I put this treatment is now ablative. That is kind of a technical description of what's actually going on with those cells, but we actually think that the cells like physically get destroyed. Instead of more the DNA is being destroyed, it's almost like there's a physical destruction of the cells. And I don't think I actually put this on here, but this is generally between 5 to 10 treatments. And so it's almost a totally different way. Instead of 5 to 5 weeks or 7 weeks of treatment, now we're doing treatment in 1 week, which this machine allows us to treat in fewer fractions because of the ability to image. So this is a picture of what this would look like on the MRI. And so the red is the pancreas or the pancreatic mass. This would be like a pancreatic head mass. The kind of brownish orange is the duodenum and small bowel. And actually this is the stomach over here, liver is here, kidneys are back here, spleen is over there. So this is just highlighting often the problem is that we have the tumor in this red, but then you have organs just adjacent to it, which can make treatment, especially on a conventional machine like the treatment, difficult because you don't want to overdose the duodenum itself. You want to deliver treatment to this area right there. And so the Meridian allows us to do this. And Dr. Kinder, you were mentioning kind of about the MRI. The next slide here is actually this is actually what it looks like on the machine. So when someone is actually getting treated, this is what we look at. So this is a constant MRI, and this goes for about 20 seconds, but I can kind of go back here. So this is actually, this part is how where the machine is located. But this main thing is, so there's an MRI going and we see this view. The red is actually the target in real time. The blue is where we want the red to be. And so we ask patients to go to do a breath hold, and that puts the target right where we want it to be. And so you'll see this person actually taking some breaths, and then the person will take a deeper breath, and all of a sudden now it's in, and this little thing comes on, says beam on. And you can see the heart is beating there and the vessel down here. So it's actually kind of cool. So what this allows us to do is in real time. So this is happening in real time. We can see the tumor, the target, in real time. And the beam, and this is called gating, the beam will actually shut off if this tumor moves out of that blue, out of the target region. So the patient can help us by breathing into right where the person needs to be. And so the MRI is going continuously. So we know exactly where it is in real time. So this helps us become much more accurate and precise. So going back to this one picture, let's see if I can do that. So what this allows us to do essentially is to gate it and target it so that we are hitting this while really missing that. And that allows us to get as much dose as possible into this particular region. So again, just the gating of it. So the pancreatic data, it's relatively new, and because there's not that many centers out there doing it, but there is a study that was published. It's called the SMART trial, and this was done mainly down in Miami Baptist. And what they did is they treated people with borderline resectable, unresectable pancreatic cancers for these 5 treatments and followed them. Median follow-up was 10 months. And we can see the acute and late grade 3 toxicities were actually very low at less than 3% and actually had outstanding local control rates. So this LC local control, so 98% at 1 year where the tumor was controlled. And overall survival for these patients was almost 59%, which is actually really good for unresectable or very advanced pancreatic cancer. The other area where the Meridian can really shine is in this term I use called oligometastasis. And I put here that stage 4 is undergoing a bit of a paradigm shift. Although the idea of providing cure for people with limited metastatic disease has actually been around for a long time, probably almost 100 years actually. But how I describe it to my patients is that not all stage 4 is equivalent. So it's not just this box of stage 4 where you get placed into. We definitely think that there's a difference between people who have, I put here 5, but over 5 metastasis versus between 1 to 5. So there's something that's probably different genetically or biologically between people with more limited metastatic disease, again, between 1 and 5, and people who have more than 5. And so this has been looked at, and this is called the SABRE COMET trial. And what this did was it randomized patients between standard palliative care, which could include chemotherapy, it could include some radiation, and this idea of SABRE. And sorry, I didn't explain what that is, but that's this treatment that's very focused, only using 5 treatments, generally speaking. So it's very focused, ablative treatment, exactly what the Meridian can do for people. And so what they did is they demonstrated that in 5 years that the overall survival was 17% in patients that got the standard palliative standard of care versus 42.3% in those that received kind of that standard palliative care, which could include chemotherapy plus this very high dose focused radiation, which we called SABRE or SBRT, you might hear that term as well. So very focused high dose radiation to the area. And actually, especially with the later publications, there was actually very few grade 2 to 5 adverse events. And when they actually compared it, there was no difference between those adverse events between the SABRE arm and the standard palliative of care. But the people getting this treatment live longer. And so the Meridian can really treat these areas, especially if they're in a difficult location. Oftentimes people will develop metastasis in lymph nodes in the pelvis, or let's say in the abdomen, or even in the chest. And the Meridian allows us to go after those with high precision and accuracy. So those are the 2 main areas I wanted to highlight for everybody on the benefit of the Meridian. And that's actually what I have. So questions, anybody have any comments? Happy to answer anything.
Yeah, Dr. Clark, first off, I thought that was really interesting. It's really neat to see what you're actually seeing with the MRI when you're doing the treatment. So
it is
neat. So is that something when you're doing that, is it basically there's a tech administering it and then you're watching to make sure, or what kind, how does that actually work?
Yeah, so yeah, that's a great question. It's almost like it's a very involved process for everybody. It becomes much more of a team on kind of site. So what happens traditionally with radiation is that there are techs that give the radiation, and we're not even, unless there's something to be looking at, we're actually, as docs, we're not even really around. But we are always available if there's a question about it. But the Meridian tends to be a much more involved process for everybody. So we usually have between 2 to 3 techs actually delivering the radiation. And then we have a physicist, a dedicated physicist that's there. And then we are usually there as well. And part of that is just knowing you know, even the anatomy in the meridian isn't fixed. So things can move around, and we actually sometimes need to redo the scan, and in some cases have to redo another plan even when you're in treatment. So you almost have like two plans. So it can be a very involved thing, making sure that the person is breathing in the right way, getting the tumor in there. So, and the treatments, these can take quite a bit longer. So these adaptive kind of pancreatic plans, instead of the 15 minutes that is kind of traditionally given, the adaptive plans can take an hour, hour and a half. So it can be a much longer process, because we're actually doing a new plan when they're laying on the table, as it were, on the machine.
Interesting.
Does anybody else have questions? If so, you just have to unmute yourself.
This Carter, I was a little late. Is the radiation source here still high energy X-ray beam?
Yes, and so that does not change. The actual way to actually deliver radiation to the target does not change with Meridian. It's still a high energy X-ray.
Is there a significant difference though between the non-tumor radiation from low dose CT versus the non-ionized radiation of MRI? Does that make a clinical difference?
Actually, we don't think so. Yeah, that's actually a really good question. And I get asked that not infrequently about people getting.
Well, that's the reason your resolution is so low. You're using very low dose.
Exactly. So the actual CT scan, the cone beam CT scan we use prior to treatment, it is much lower than even like a big X-ray that we would do, like a chest X-ray for visualization. Yeah.
Thank you.
Yeah.
Okay, I have another question. So I know you said that you're doing high doses for this. Is it the same cumulative dose of radiation? You're just giving it over a week as opposed to 7 weeks?
That's an excellent question. So actually in most of these cases, we actually are wanting to deliver more radiation, and we call that a biologic equivalent dosage, or a BED. For a lot of these tumors, we're actually trying to deliver more than what has traditionally been given. So for that pancreatic cancer, let's say, whereas traditionally we'd give 45 to 50 gray, biologically with the 5 treatment, it would be more like 100, over 100 gray.
Oh, wow.
So you're getting in much more dosages. Actually, what the tumor thinks it's getting is much higher. And so again, for a lot of these tumors, we actually think that that's the biggest thing, is we need to escalate the dose. And traditionally that's been a problem, because we can't see often well enough to feel confident in escalating that dose. But with this, now we can see, so there's a higher level of confidence of actually escalating that dose.
And you're able to give a higher dose because you can contour it better to avoid the surrounding tissues.
Yes, that, and then on the day of treatment. So this is a thing that would happen, is that someone would come in, they would get a mapping CT scan with us. That actually would be a good quality, and they would have IV contrast. And we'd be like, oh, there's the tumor, you know, I could accurately delineate it and come up with this really nice plan. And then on the day of treatment, it's like, oh man, now I'm not exactly sure where it is. So and that's because there's such a difference between the scan quality, and then the person is just moving too. You know, when they get the mapping scan, that's just, you get kind of this one-time view, but on treatment, since it's over, 5 minutes of length, you actually don't know, even though we have techniques to try and limit it, you don't often know what's going on internally.
Are people talking about using this for head and neck cancer now too?
Yeah, so my other partner, Dr. Yi, he actually just treated a larynx in this way, 5 treatment larynx. Most people are not, I don't know of any centers that are doing head and neck with this right at this moment. And it's almost a problem with just recreating a plan. It becomes, on the machine, what we're finding is it's very, very time consuming and laborious to do that, especially for head and neck. So at this moment, all the head and necks are still being treated on the other.
If this wasn't such a time-intensive process, what other sites do you think would be suitable for this, say, lung or
Yeah, there
whatever?
are people, right, yeah. So there are people that are treating all sites. So there are places that are treating brain in this. There are people that are treating lung. Things in the mediastinum are being treated. Anything abdominal and pelvic, including prostate. Right now, we have 4 patients right now that are getting treated for prostate cancer with this machine. So most of I think almost everything is opened up. I think in some respects since we've been only doing this for about a month, there's still a pretty significant learning curve in this machine. But even in centers that are really, really experienced, even their kind of complicated pancreatic cases take an hour to do or more.
Do you think this is kind of the way radiation is moving though? Will we eventually be doing everything with this as opposed to the CTs?
Yeah, I think that there's probably still always going to be the role for the kind of traditional, quote unquote, traditional CT based thing, especially in areas that don't move very much, or we're not worried about normal organs moving into it. Breast cancer, for example, there are centers that are treating breast cancer with this, but by and large, I think that is an area where the Meridian wouldn't be used all that much, just because you usually have a lumpectomy site that is usually free and away from other organs, and it doesn't move all that much. So, but I do think that our field as a general rule is moving towards getting treatment done sooner with less treatments compared to what was done even 7 to 10 years ago. Whether that's done on an MRI or on the traditional machine, I think is still up in the air. I think the general trend is definitely moving towards fewer treatments for everybody.
Well, and I think it's great you're able to even further contour your field, because I feel like when I was going through med school, they talked about IMRT and how that was such a big thing, being able to preserve the salivary glands
Right.
and the constrictor muscles and things like that. And still, even with that, I think it's better than it was, but patients still have a lot of long-term side effects. So,
Oh,
if
man,
you can
right.
contour even further, I think that's only helpful.
Right. I agree. Yeah, you definitely see our patients that are suffering the most. But yeah.
Well, thank you so much, Dr. Carter. Dr. Clark, I'm sorry. Dr.
Oh.
Carter's on the line. I just wanted to
welcome.
see if anybody else has questions, and that we have recorded this and it will be available on the Buchland Medical Society YouTube channel.
And thank you so much for all the questions. If anybody else has questions, or you can always just shoot me an email, jonathan.clark@enlo.org.
It's almost Friday. That's what. All right. Well, thank you all. And thank you all for all that you're doing. We know that the surge right now is impacting everybody. So tonight actually is the Physician Lounge at Wine Time on Lost Dutchman Drive in Chico. So you're welcome to come by and have a drink or some small bites, courtesy of Buchland Medical Society. All right, well, thank you, everybody, and thanks for giving hope. I have 2 friends who were lost to pancreatic cancer in the last few years, and just watching this, I knew that there's hope for future patients.
Thank you for having me. I appreciate it.
Okay, thank you all.
Bye, everybody.
Thank you.